So thank you all for joining this lunchtime webinar. We hope that it will be a useful hour of your time. This webinar is being delivered by the Royal College of Pathologists in partnership with their corporate member, Roche Diagnostics. This is the second in a series of 3 webinars covering the 3 shifts outlined in the government's 10-year health plan. My name is Dr Natasha Ratnaraja, and I'm a consultant in infection at the University Hospitals Coventry and Warwickshire NHS Trust. I'm also the chair of the RCPath Medical Microbiology and Medical Virology Specialty Advisory Committee. Our speaker today is David Linden, Dr David Linden, apologies. David is currently Respiratory and CVD Workstream Lead at Health Innovation Yorkshire and Humber and Respiratory Programme Lead at Health Innovation Network. He has over 30 years of senior leadership experience across research, product development, marketing, and commercial strategy in healthcare. Following David's talk, there will be a Q&A. Please post any questions you have in the Q&A box at the bottom, and we will try and cover as many as possible after David's talk. You're able to view others' questions and upvote any that you particularly feel that is relevant, and I will tend to focus on the ones that are more upvoted. For the Q&A, we are delighted to be joined by Sheila Devaney. Sheila is a senior medical manager at Roche Diagnostics, specialising in infectious disease, and she helped lead several respiratory point-of-care testing pilots across the UK. So RCPath and Roche Diagnostics, as we said, are collaborating on a series of 3 webinars, which the final one will conclude in February next year. And the objective is to highlight how diagnostics and pathology are critical to the successful implementation of the NHS England 10-year plan. A co-badged white paper on diagnostics as an enabler of the plan will be published by RCPath and Roche in April next year. And the themes related to the shift to community in the 10-year plan are likely to be touched on during today's webinar. So we're going to just be conducting some polls during this webinar to provide us with some insights we might draw on for the white paper. We'd be grateful if you could take a minute or 2 to complete the polls now, and there'll be a couple more at the end. Thank you. We're actually getting quite a good response. So while you're still voting, just finalising the voting, I'll read out the question so that we can share the results in a second. So does your current laboratory hospital system integrate data from community-based point-of-care testing, for example, care homes, for respiratory viruses, flu, COVID-19? So you can see that the majority of you, 65%, said no, we only process hospital clinical-based samples, with only 10% consistently and 7% in specific scenarios. So moving on to, some people have answered all the questions now. So the second question is current practice. Approximately what percentage of your patient population requiring respiratory virus testing do you estimate is managed outside of a traditional hospital or clinic setting, for example, care homes, community hubs, ARI hubs? And 51% of you say you don't know, which I can imagine is a fairly widespread answer. Less than 10%, 25%, and 60% said 10 to 25%. And I guess it's because we just don't test in the community. And the third question is, which factor do you believe is the most significant benefit of rapid community-based point-of-care testing for fluid COVID-19? And it's quite evenly spread between improved infection control within the community setting, 32%, reduced inappropriate testing, 26%, potential for earlier hospital admission or treatment, and 17% for faster turnaround time. I'm now going to hand over to Dr. David Linden.
Yes, good afternoon. It's morning, afternoon, it's afternoon. So good afternoon, everybody. Yes, I'm David Linden. I'm the Respiratory and CVD Workstream Lead at Health Innovation Yorkshire Humber. I'll talk to you today about hospital to community partnering to transform respiratory point-of-care testing. The slides move, actually to move. Okay, so initially I'll just give you a bit of an overview of the Health Innovation Network, a summary of what I'll talk about today, and then I'll go into a bit of detail about the challenges and solutions that we face while implementing a couple of evaluations across our region in Yorkshire, and then talk about the evidence and benefits we found. So the Health Innovation Network, very briefly, it is an organisation of 15 different companies. We cover England, and we are funded by UK NHS England and the Office of Life Science. And our aim is to identify, evaluate, and then spread innovation within the healthcare system. So today, this is just a bit of a summary about the slides we'll go to. Challenge, well, we all know respiratory viruses are quite prevalent over, well, prevalent all year, but particularly in winter, as we're all inside, being cold as it is this week. Spread quite dramatically, and they can obviously cause quite a lot of problems for people, and that relates into hospital attendances and beds, which has been reported in the media. These are examples from last year. So I'll talk to you then about a solution, which is the point of care testing within a community pathway. Lots of benefits to this, both for the patient, not having deteriorating as much, through to appropriate treatment for the patient. And also the good thing about point of care testing for flu, COVID, as we've done, and also things like CRP, it aligns with government policy. The 3 shifts, which are currently talked about quite a lot: community to the hospital, sickness and prevention, and analog to digital, meets all 3 of those. So it's a good opportunity to get a pathway into the community system and help meet those policies. So, okay, a bit more detail. We'll talk about the challenge. So, influenza, yeah, it's recognised by the NHS as one of the primary factors in winter pressures. As you can see from this data here, across the board as well, through primary care, multi-million consultations happen every year. And then into secondary care as well, with A&E visits, hospital admissions, and resulting bed days. This is data from a couple of years ago, which is most recent in NHS Digital. And that last year transposed into quite a number of media coverages, which highlighted the fact that on a daily basis through winter we were getting up to 5,000 beds being taken by patients with influenza and respiratory illnesses, and about 100,000 beds, for example, were just lost in 1 month in December. So it has quite a big impact on secondary care at a time when it's already stretched. So what are the challenges in the system at the moment? Well, flu, COVID, chest infections can be difficult to distinguish. They present with similar symptoms in some cases. If that's the case in primary care, you can take a throat swab, send it off to microbiology for analysis. That tends to take a few hours to a couple of days. If you're using it for maybe isolating and knowing where to move patients in secondary care, maybe not as important, but in a primary care setting in the community, that's quite long. And by the time, obviously, you get the results back, the patient's gone home. So ideally, you'd want something a bit quicker, so you can talk to the patient about the results there and then. Also, if that patient's eligible for antivirals to try and prevent ongoing deterioration, that antiviral needs to be taken within a 48-hour window. So obviously the speed of test is quite paramount in that situation. Sometimes when it's unclear what the symptoms are, the GP may be then waiting for a swab, and results may then prescribe antibiotics. So it can actually lead to prescribing more antibiotics than potentially is required, leading to AMR problems. So a good opportunity to look at what we're doing and try and optimize that. So one potential solution and way of doing that is by this test and treat influenza pathway. So over the last couple of years, our HIN organisation, through originally the Northwest Coast and then as in Yorkshire Humber, have been developing various different pathways for community use of point of care testing. So this is an example on the right-hand side there. That was a pathway that was developed for care homes, and we enabled the diagnosis to be changed from about 72 hours to about 24 hours in that particular case. Or should I say within 24 hours. So there's advantages of obviously getting timely diagnosis and timely treatment. It also helps with diagnostic confidence with the clinician making that diagnostic judgment. And it also helps once you know if the patient is infectious or not, potentially with impacting and reducing the spread of infectious diseases if you're in a care home situation. Now, the pathway which has been developed is test agnostic. So it's not promoting any particular test in that pathway, and there's a multitude of tests which are appropriate, going from benchtop analyzers, portable analyzers, and also lateral flow devices. Now, all these three different types of category, there's lots of different devices in those three categories. There are pros and cons, from some being a bit more portable than others, obviously lateral flow devices more so than benchtop analyzers. But there's also then trade-offs with things like cost and also portability. So it's quite useful to know what those advantages, disadvantages are for the different devices before placing them in a setting, because there's what may originally seem like the best device might not be the best when you start looking at what's required. For our particular use case, which is the test and treat influenza pathway, we were looking at trying to reduce antibiotics and increase antivirals. So our population for this use case was particularly interested in those patients who potentially could receive and have be treated by antivirals. So that is defined by the UK HSA, UCAS, as over 65 and clinical at-risk patients, which are listed there. To give you an indication of how many that is, quick analysis was looking at around about 21 million. So we're talking about millions of patients potentially could be eligible for a test rather than hundreds or thousands. So quite a significant number of people could benefit. It's worth noting as well, although I'm going to talk about in more detail in the next slide about the point of care testing with the pathways. It can be used, point of care testing, in obviously many different situations. And this is one example in the ED, which is also in Harrogate in our region in Yorkshire for infection control. So again, it's understanding what the pathway is and where the use case is before factoring all that into the decision to decide on what test you're going to be using. So as we touched on earlier, one great thing about point of care testing for flu, COVID, chest infections is that it matches the three shifts in healthcare, as you've been talked about for the last sort of year or so since they were brought up by the government about this time last year. Hospital to community, a lot of these pathways we're talking about, we're ideally putting the point of care testing in the community. They included primary care, care homes, and inpatient community wards as well. So we're matching that quite well. Sickness to prevention is matched. We're getting in early. We're doing quite an early test, hopefully with the patient, understanding what the condition is, and giving appropriate treatment so the patient's not deteriorating. So we are meeting that sickness to prevention, trying to prevent ongoing deterioration. And analog to digital. Within the different evaluations which were done in Yorkshire and the northwest coast. We used a digital app into which the patient's observations could be inputted along with the test result. That calculated a U2 score, and in certain cases, that results be electronically transferred to the primary care setting from care home setting. Enabling a remote diagnosis by the GP. So they didn't have to go out and swab or do a test in the care home. There's also other solutions out there as well for seamlessly transferring data from the test results into the patient's digital records and into the lab system, and also ongoing as well into UKHSA, into UXA's reporting system too. So again, really good opportunities to meet all three of those three shifts. Using this approach as well also meets best practice guidelines, which have, in this case, showing being delivered by the PCRS, the Primary Care Respiratory Society, who suggest initially using a COVID influenza test and then pointing the patient down either the COVID or influenza pathways if that particular patient has a positive test result. And then with a negative test result, potentially going on to utilize a CRP test, which then gives, depending on the CRP test, an indication or a weighting of the bacterial load, so then you can start making decisions about whether it's appropriate to prescribe antibiotics. And as well as the PCRS guidelines, similar guidelines, similar tests are promoted by the NHS as well. So this is an example of pathway, quite small, very difficult to see there, but this is a pathway which was recommended by NHS when setting up ARI hubs, for example, in primary care. And again, using a point of care test for influenza and COVID first, that may send a patient down if they're positive, down a pathway for COVID influenza, then if not, using a CRP test to understand the bacterial infection and whether it's appropriate, maybe just prescribe, in that case, antibiotics. So next thing, let's go through some of the evidence and the pathway evaluations which were done over the last couple of years. So I'll talk about two in brief. The first one was done in 22-23 winter season, and then the next one was done in the 23-24 winter season. So the first one was GP practices, walk-ins, patients, and in care homes as well. And then the following year, the same GPs in care homes, but also added community wards. I think the difference between the two was in products which were used. So the first year we did this, we used a benchtop analyzer, which was situated in a GP practice. And then in the second year, we used lateral flow test devices. And they were housed in GP practices, they were housed in the community wards and the care homes. And worth noting as well, both these were collaborative working agreements as well, which were funded by Roche. So going through a bit of detail on the first phase 1 trial which we did, evaluation. It was a three PCNs and multiple care homes, which those PCNs supported. Again, the cohort was over 65, so it was this at-risk group who could benefit from antivirals for flu. In all, we tested 250 patients, and the data we collected was on day 1, and also a follow-up at day 7 and day 30. So out of those 250 tests, we had 33 positive for flu. We had 23 of those were prescribed antivirals, and 6 were prescribed antibiotics. It was also important to note that we've tried to model how many people we anticipated would actually end up in hospital, even with going through this pathway. And the predicted modelling suggested that we would still have, the predicted modelling suggested that we would have 18 people, if they didn't go through the pathway. And also predicted that out of those 18, one also would be an ICU case. What we did then find out with the pathway in place, that we only had one hospitalisation and we didn't have any ICU admissions or deaths. So you can see there that we were also showing that we had good number of patients who we would anticipate potentially going through and taking up hospital beds and time in hospital didn't actually transpose due to the pathway. Part of that evaluation, we delivered a patient survey. And one of the key findings that we found that out of that patient survey, 95% of those patients would have recommended this new way of testing, point of care testing, and the pathway for treating their flu symptoms to their colleagues and family. Now going into phase 2, which is the evaluation we did in the following year. Similar, we used GP practices and care homes. They were not the same care homes in some cases as the first year. This was purely in Yorkshire, where the first evaluation was in the Wirral area and also in Yorkshire. We had the same cohort because we were looking at trying to encourage the uptake of antivirals. In that year, we had 100 tests being delivered, lateral flow devices, and 100 out of those 100 tests, we had 59 collated on patients. Results collated on patients. We used lateral flow device, which is interesting. We offered very different devices across all the different settings, and every single setting preferred in this situation a lateral flow device for its ease of use and ease of training as well. That most of the staff were already trained on using lateral flow devices, which wasn't the case with the digital analyzers. We collected data on a similar analysis that we did on the first year. In this case, we did it at day 0, and we also did it at a follow-up of 30 days. This is a diagram of all the different people who were involved in that particular evaluation. And it's worth noting that one of the key aspects to getting this evaluation delivered succinctly and on time was the team effort that everybody had. And we've got everybody working collaboratively as a team, shared interests, shared goals, which made that we delivered it on time and ensured that everybody was on board and happy with the outcomes and results. So going on to the results, we had 59 people tested. Although we had over 100 tests being performed, we'd only be able to gather on 59. One of the difficulties, obviously, with doing these evaluations within the flu season and winter pressures is that everybody is very busy. So unfortunately, we lost a few of the patients. The staff didn't gather the data on those particular patients in time. We also had some staff as well testing them on themselves, and they found additional benefits that by knowing if they were positive or negative for having COVID or flu, enable them to be at work and deliver care in the community, which was a very, very interesting information to use, although it was particularly out of scope at the time with the evaluation we were doing. But out of those 59 people, we had 9 positive for flu, and out of those 9, 6 were prescribed antivirals, and only 1 was prescribed antibiotic. And again, interestingly, we didn't have any hospital admissions or ICU admissions due to flu or COVID. Out of those prescribing, antivirals and antibiotics, we noticed that 36% of the treatment decisions were influenced by the point of care test. And also the number of antibiotics used was decreased by 25%. So when we're talking about 67%, 6 out of those 9 people was prescribed antivirals, we had a look and see how that was aligning with what was being previously reported in the literature. There's been a couple of different papers from Australia and the US who've looked at that in a bit high numbers than we had here, more than 59. And they were finding it was roughly between about 15 and 20%. Some cases up to about 30, depending on the setting. But in general, 15 to 19% there with that particular paper, Havers. So you can see that the 67% that we found was quite a lot higher in our evaluation. So this pathway was helping people access antivirals. And said it also helped reduce antibiotics. We found, it was 25% are actually reduced by looking at the data of what they would have prescribed compared to what actually was prescribed. And then when we even were looking at what we actually was prescribed, that 11%, 1 out of 9, and comparing that with the literature, we found it was generally about 41% of people in that situation would be prescribed antibiotics. So again, it was quite a lot lower than what normally would be prescribed without having a test. And even when they did have a test in this literature, that was 29%. So in the studies that we were showing, quite a lot lower than that. In our second year, we didn't do a patient survey, but we did a healthcare professional survey. And notably, again, out of all the different questions we asked, all the results were strongly positive or positive. There were no negative or disagreeing replies back at all. So all the particular healthcare professionals valued the test, the pathway. It helped them with their conversations with the patients, and also it helped their prescribing decisions. And then the last one at the bottom of that set of pies there, it was interesting that having the negative diagnostic test, they were saying that it helped them prevent unnecessary isolation of the patients. These are some of the feedback that we found from those healthcare professionals, which noted it reduced anxiety in the patients because they could see what the test results were straight away. The tests, the lateral flow devices, took about 10-15 minutes to get a result back. And usefully as well, by the patient seeing the result, that helped the patient accept that they needed to isolate. And that was particularly in the case of some of the mental health wards where this was delivered. And again, the one on the right-hand side there highlights the fact that by doing this test earlier on, it helps that prescribing decision, and they could prescribe antibiotics or antivirals early, so it prevented deterioration and secondary care emergency. Alongside the analysis we did of the results, the data, we also did a modelling, and that predicted the following results. So we looked at a reduction in hospitalisation was predicted of 96%, reduction in death, again, really high at 94%, and then, importantly, reduction in costs. So if you're doing the early diagnosis, early treatment, then you can reduce the numbers of isolations that need to happen. So there's a big cost saving in staff costs for that. So the normally when you get an isolation, the staff ratio needs to go up, so you're avoiding that, and also you're avoiding the deep cleans afterwards as well. So there's quite a lot of cost savings to be had in secondary care and care homes. Less so in GP practice environment, so we're looking at the reduction in cost there was about 61% per patient, rather than the 91% we were finding and predicting in those hospital and care home environments. One of the challenges we did have when we did it in the second year was we were doing the evaluation in a flu season which wasn't particularly high. In 23-24 it was quite low compared to the previous year and successive years as well. So last year and this year as well, we're in a potentially quite a high flu season. So the evaluations which have been ongoing this year will hopefully find and deliver a lot more data than we did. So this is a summary of the evaluation side by side. And it's interesting to note that they're quite similar in outcomes. So looking at the number of cases which were positive for flu, A or B, 13, 15% in the two different studies. Looking at how many antivirals and antibiotics were prescribed compared to those positive cases. Antivirals was about 70%, antibiotics about 18%. And then similar when we're looking at how many were prescribed compared to the total cohort who went through the pathway, the 9 and 2 there and the 10 and 2. Again, quite similar between the two different studies which were going on there. So, to summarise, looking at some of the benefits that the point of care testing can do in the pathway. You can shift in that diagnosis predominantly into community. That really is paramount to getting the patient an early diagnosis and early treatment, so it's preventing the deterioration. A test can't give you a definitive answer whether somebody has flu, COVID, chest infections, but it does enhance that clinical decision making, and is a very useful tool to have for the clinician. It does increase the patient's confidence in the decision as well, having that test, and especially being showing the test and the test results as the patient goes through that dialogue with the healthcare professional. We found that both of these studies do reduce antibiotic use, and it does enable this timely antiviral treatment for those patients who are eligible, and that has led to people remaining out of hospital. We've seen a decrease in the number of people we predicted would actually end up in hospital without going through this pathway. And we've shown as well that it can be used in a number of different healthcare community settings, for primary care and GP practices, area hubs, community wards, and care homes. So I'd like to leave you on this last slide. There's been quite a lot of evaluations. I've already talked about 2, but there's quite a lot actually have gone in the Yorkshire area. As you can see there, there's about 6 or so location markers in Yorkshire. There's been some as well. I've been gathering information up from Scotland and down in the southwest too, and in Oxford. But quite a lot of these are quite small numbers of patients. So an ask to everybody on the call today that if you are involved with any evaluations going forward, yourself, or if you're aware of any in your region, please feel free to reach out to me. And my email address is on the next slide. It was on the first slide in these presentation. Please send me your test results, evaluation results. I'd like to collate all those and try and have enough test data then to see what we can do to roll out this on a national basis. So thank you very much for your time today and listening, and hopefully you enjoyed that, and please feel free to ask any questions. I'm here with our colleagues from Roche to answer questions that you've got. So thank you very much.
Thank you very much, David. That was a fascinating talk, and just hearing about the 25% reduction in antibiotics is quite pertinent, given that it's World Antibiotic Awareness Week and today is World Antibiotic Awareness Day. So thank you for that. We have a couple of questions. We have more than a couple of questions now. So I will. It's actually quite a few now. So one of the attendees has said, despite it being a government agenda to improve community care and use point of care testing, I'm unclear where the funding comes for the introduction of the community pathways and point of care tests.
Yeah, it's a very good question. I think it's from the evaluations that we've done and the ongoing testing that has been happening in Yorkshire. It's generally been at the trust and ICB level. And I guess that's primarily because in some of the community settings, the overwhelming benefits are in secondary care. So, for example, trying to implement it in a GP practice where all the GPs are set up as their own little businesses or big businesses, it can be quite a difficult business case to show that there's financial advantages to the GPs. It has been shown that in some of the other evaluations I've seen that it can stop repeat visits to the GP practices, but on the whole, a lot of the advantages come through to secondary care and reducing that hospitalisation. So it is at that overarching trust level where it's possibly easy to put a business case together to get the pathways.
David,
it's worth. Sorry, go on, yeah.
No, it's all right. Carry on.
It's worth noting that there has been a national funding call, which had just gone out a couple of months ago and closed, to gather data, which we're hoping from that as well to understand where best place to put the point of care testing and how that can be funded.
Thank you. There's now an awful lot of questions. Nobody's had time to upvote. So, and they're all kind of related, and a lot of them are related. So, in terms of what you just said with the hospital funding it, does this mean? Sorry, I'm just going to ask you a couple of them that are all related at the same time. Is the hospital laboratory? Does that have oversight and governance and maintenance of the point of care test? Because that's another person asked. Where's the governance for this? And I think you did put a brief slide of costs. Yeah,
there's a big cost reduction. 60% up to about 90% in hospitals of a patient going through the pathway.
And
so there are costs there. Most of those reductions are in secondary care rather than primary care. So if you're in a care home or in a community ward or hospital situation, then you are recouping those costs directly. Some of those costs are cash releasing, but only a small proportion. A lot of the costs are in bed days. So it's the reduce of having a lot of patients clogging up the beds and the system and deep cleans. So again, it's a tricky one because quite often you're wanting cash releasing benefits rather than the beds already paid for, whether they're full of people with flu or another ailment.
Thank you. And I think a lot of the questions have said, do the costs include the test kit, the reagents, and the staff? There's
yes.
The staffing. Yeah, they do.
So the cost when we were modelling the costs out included all the staffing, the test kits as well.
Brilliant, thank you.
I think one thing it didn't, because our modelling was on the lateral flow device. So one thing it didn't include in that was if we were putting in a point of care test which was needed reagents and ongoing maintenance and or calibration, that may then sort reduce the benefits, the cost benefits a little bit. But that probably would only be a small amount compared to the vast cost benefits from the bed days and the isolation costs.
And I think anybody who's on the call would know about bed days being a very difficult thing to
And I think, David, that was factored in the first pilot where it was the LIAT that was used. Those additional reagents and calibrations were included in the cost analysis for that one.
Yeah.
Okay, so you did, Tom, there's so many questions now that I'm trying to put them all together.
Yeah, I didn't present the data on the first one, which had some of the cost reductions in as well, but that also, so as Sheila rightly said, that used the LIAT, which is a benchtop analyzer, which also saw dramatic cost reductions as well.
Okay, and these tests also included COVID-19, didn't they? Or they
did,
just
yeah,
but not RSV.
The ones we tested, no, they were purely COVID and flu.
Brilliant.
Yeah,
Okay.
so they were multiplex that were flu COVID, but there is the option to do COVID RSV as well as a point of care test.
Thanks, Sheila. And there's quite a few questions about sort of the sensitivity and specificity and validation, those tests.
So we did a analysis of the sensitivity and specificity. It's sometimes a bit tricky to compare like with like, because a lot of the data from the lateral flow devices to the traditional more benchtop analyzers use different systems. Some of the purely flu-related lateral flow tests tend not to be as accurate, whereas the flu COVID ones, especially the more recent ones, tend to have quite good accuracy. So the accuracies that we were aware of and the ones we chose were the ones which were quite high, in the high 90s, which were above the minimum values recommended by WHO, as these are the sort of tests that you need to be using in that situation.
Okay, because I think but
there's a trade-off between, if you are going to go down the lateral flow device route compared to the benchtop analyzers, which are obviously a lot higher. And I think going back to one of the previous questions, the path labs, should have sight of those if it's been implemented somewhere, so the governors potentially could come through the path labs. I think that's a discussion point depending on which region and where you are and how you want to implement it.
I will say that is something that RCPath is saying, that really it should be the path labs that have the oversight and the maintenance, and that might lead me onto one of the other questions, which are coming thick and fast now, is the mainly the interfacing. How did you get the results from the community? And I would have said, especially with the lateral flows, but also the PCR into secondary care and to UKHSA.
So the test results were done in the community. I don't think it was the responsibility of whether it's the community wards or the care homes then to alert UKHSA. So in the modelling we did in our pathway, that wasn't automated. There are automated ways of doing it. So, for example, I showed the slide of Harrogate who use it in ED, and that they have an automatic way of scanning the result, and that all goes through to an automated UKHSA alert system. When we were doing it, it's a manual process. And I guess one thing to mention about that as well, it's not always known that if you get a positive flu result, that has to be reported to UKHSA. UKHSA are aware of that as well. And
I think with the first pilot, the health call app was used, so there was that electronic uploading, but we didn't use that in the second one. But there was kind of a process in place so that all of the results would be sent forward and sent to the appropriate physicians and to the UKHSA.
I think also, I think from reading the question, and actually it would be my question as well, is the whole how do the secondary care get those results so that you avoid duplication of results and testing, and just you have those isolation measures if they present to hospital. I know you increase hospital avoidance, but just there will be the odd person that would present.
Yeah, I think again that was something which will be done manually. We were looking at doing some other evaluations this year, trying to automate that, so that you can scan results and that goes into the patient record straight away, and it's transferable. So when you go into ED, you don't have to, because there's quite a few EDs now where you've got that point of care testing, you don't have to repeat it. It's already done, so your patient's not waiting in the back of your ambulance potentially while the test is happening, or in an isolation room while that test is happening. That's not something we did as part of the study when we were doing that evaluation, but it is a very useful way of reducing costs and speeding up how that person is handled in the pathway as they go from primary to secondary care.
Thank you. So I'm just going through all the questions. Yes, somebody's noted these were multiplex flu and COVID. Apologies if missed, but the results presented only included flu A, flu B. Are there any results or analysis for COVID?
Yeah, so it did measure both and we did record both, but I suppose the data on these were specifically for flu test and treat pilots, which is why that's what David has presented. But I couldn't put my hand on it right this minute, but we could find it. We did have a couple of positives for COVID as well in each of the scenarios.
Yeah, I think in the second year we had two or three who were COVID, and similar. I think there's quite a few more in the first year. But
yeah, relative to the number tested, and we had a pathway for each. So if you were positive for COVID, obviously you followed the standard COVID pathway. If you were positive for flu, you followed the flu pathway.
Okay, and following that pilot, have those two regions taken up the test, and are they using it as standard investigations now?
I don't think either region is. We're trying. Yeah. I think the tricky bit is the data. So when you look at, we're presenting it quite frequently, as much as we can, and everybody that you present the information to really so far when we're doing that face-to-face is being received very well and positive. The difficulty is having that money to upfront load the system to get the benefits, based on the fact that we've only got, when we pool these two tests together, or two evaluations together, we've only got 300 tests. So to release that money on a few tests is quite a difficult ask, which is why we're trying to build up that evidence base. I do know from CRP testing, which has been happening in our area, when they've got to the state where they've got thousands of tests, that has got ongoing sustainability. So that's been going for about 2 years on a trial, and then we've now got 3 years, the next 3 years of that. But that's because there's the data there. So partly there has been this national program go out and funding to fund at least one valuation in each of the 7 NHS regions. I think that was put out by the AMR, Central NHSC team. So we're looking at trying to pool our data and work with them to gather as much data as we can to say what we're talking about, the benefits we're realizing from the number we've got are actually what you're getting in reality.
Yeah, it's really been that siloed budgeting that kind of has been the blocker. So yeah, we continue to try and increase the amount of evidence. And as David mentioned, a number of the CRP pilots have been able to commission subsequent to the pilots because they've had enough data to make that shift.
Thank you. And presumably you tested over the winter season on those 2 pilots.
Yeah.
Brilliant. Thank you. Thank you very much, both of you. That's been a really exciting talk. We've got a few minutes to do the final poll. If anybody wants to contact you, is that sort of, if they're interested in trying to do a pilot, is that something you'd be open to?
Yeah, absolutely. Reach out.
Yeah, please get in contact. Like I say, my email's on the, if this recording is available, it's on the first slide and the last slide of my slide deck. So happy to receive any calls if you're interested in putting an evaluation together and need some advice and guidance on that. Happy to have a chat and give you some of the pointers that we found from doing this over successive years.
Brilliant, thank you. That was a really fascinating talk and a really good discussion. And thank you to the audience for being so involved with the Q&A. Sorry we didn't get to go around everybody's. I'm trying to join everybody's together. But as mentioned before, we have a few more polls now. So how confident are you now in your understanding of the clinical pathways enabled by timely community point of care results? Reassuring to know that the majority feel either confident or somewhat confident, and I'm glad to see some people feel very confident. In intent to practice change following this presentation, how likely are you to advocate for or investigate the integration of community point of care data into your local respiratory virus testing strategy? And 74% of you have said likely. So David and Sheila, you might be having some emails, I think. And then final question, do you agree with the statement, the benefits of rapid triage and targeted treatment for respiratory viruses outweigh the logistical challenges associated with integrating community-based point of care testing data? And about a third of you are neutral, 55% agree, and 7% strongly agree. So I think there's a case to be made. I hope you two feel quite assured by that. And I feel quite assured because it is hard. It is hard for us to write business cases, I'll be honest, but it is, if it's worth it, it's worth it. So thank you very much for joining us. And thank you to everybody for joining us today. I hope you found it worthwhile. Do keep an eye on the college's CPD events calendar. You can scan the top QR code here to access it. And as mentioned, the next webinar in this series will be open for booking shortly. We'll be emailing everybody a feedback form. Please do fill it in, as it does help us shape the college's programmes of educational webinars. A recording of the webinar will be circulated shortly to all of those who registered and will also be uploaded to the RCPath YouTube channel. And do have a read of the recent Power of Testing report, developed by Roche Diagnostics in partnership with the Institute of Biomedical Science and supported by the Royal College of Pathologists. And it was going to be scanning the bottom QR code, but that will come, you'll be able to see that online. Thank you. Bye-bye.